Okay, let's dive into some of the basic science behind Alzheimer's. There are two main pathological findings that you're going to want to know about. One is plaques, and the other one is going to be tangles. So amyloid plaques and tangles. Let's first talk about amyloid plaques. So plaques in general can be seen in normal aging, but there's very specific types of neuritic plaques that can be associated with dementia. So more of these neuritic plaques that you might see, then you'll have a higher chance of having a clinical dementia. Let's talk about this right here, which is really your pathway for creating these amyloid plaques. So you start off with this amyloid precursor protein, and then you get these secretase enzymes that split it into a smaller fragment, and then yet another secretase called the gamma secretase that splits it off into smaller fragments. And for the most part, we want to pay attention over here. We have this A beta 40 and this A beta 42 fragment. The A beta 40 is much more commonly made, but in pathological settings, such as in Alzheimer's, this A beta 42 becomes much more frequent, and that is where you get these amyloid plaques that lead to your Alzheimer's disease. So let's jump now and talk about neurofibrillary tangles. So Alzheimer's disease, these tangles, so these are not seen in normal aging, unlike the plaques that we saw before. So any sort of tangle is pathological, or is a pathological finding consistent with a dementia. It's consistent with Alzheimer's disease. So these neurofibrillary tangles are made from intracellular tau. And so a lot of people will refer to Alzheimer's disease and a few other diseases because of their association with this tau protein as a tauopathy. So if you ever hear that, that's what they mean. Tau is a microtubular scaffolding protein, so basically the structural component for some of these neurons. And what we think happens is that A beta 42 protein that we were talking about before, that causes some inflammation, causes this tau to become phosphorylated, leading it to precipitate and bundle into these paired helical filaments. And then as a result, they precipitate and wind up here as these neurofibrillary tangles. And it's thought that these fibrillary tangles are toxic and lead to neuronal death. So let's talk a little bit about genetics in Alzheimer's disease. So the first thing we'll talk about is the amyloid precursor protein gene. And if you remember from our diagram, this eventually leads to A beta 40 and more notably in this case, A beta 42. So only a very small percentage of Alzheimer's disease is familial. And when we say familial for Alzheimer's disease, we're really referring to an autosomal dominant form where the age of onset is younger, often in the 40s as opposed to the 80s, like we've been talking about. This amyloid precursor protein is encoded in chromosome 21. And I think the most notable thing about it is that in the setting of trisomy 21 in Down syndrome, there can be an association between that diagnosis and early onset Alzheimer's, likely because of a gene dosage effect, because these folks have 3 copies of that 21st chromosome. The next gene that we'll talk about is presenilin. So if we're thinking about familial Alzheimer's disease, this is probably the one to think about more. And this can either come in from chromosome 14 or chromosome 1. And basically, it acts as a cofactor to this gamma secretase. And what happens is when it interacts with this gamma secretase, you get more of this A beta 42 being made. So when you think of presenilin, think of your familial Alzheimer's disease. It acts as that cofactor to create more of that A beta 42. Lastly, maybe the most important thing to know is this ApoE protein. And so apolipoprotein E, and we'll get into the genetics of this in the next slide. It's a little bit complicated. It plays a role in the deposition and the clearance of A beta protein. Depending on your genetics, you can have a higher risk of having sporadic onset Alzheimer's disease. So basically, think about this gene as increasing your risk for having sporadic onset Alzheimer's at an older age. So basically what your typical Alzheimer's looks like. The genetics can get a little bit complicated because there's 3 common ApoE alleles. And there's 2, 3, and 4. The one to keep in mind is the ApoE4. So if you're homozygous for ApoE4, you have a higher increased risk of Alzheimer's disease. So, but because there's multiple forms, a 2, a 3, and a 4 allele, it isn't a simple autosomal dominant type of inheritance for this. So let's talk briefly about Alzheimer's treatments. There's really two classes that we'll talk about. One is going to be acetylcholinesterase inhibitors. The other one that we'll talk about are NMDA receptor antagonists, of which we'll just mention memantine. So this first class of medications, acetylcholinesterase inhibitors, there's 3 medications, galantamine, donepezil, and rivastigmine. They basically all work the same and have the same efficacy. And what they do is they allow more acetylcholine to be available, as we think that one of the primary pathologies or the primary neurochemical change in Alzheimer's disease is this depletion of acetylcholine. Like I said, there's no difference in the efficacy between these 3 medications. It's thought that that these medications can delay the loss of independent function by about 12 to 18 months in most of our Alzheimer's patients. The common side effects that you have to warn your patients about. So GI upset, I think, is the big one. But some patients also have insomnia or vivid dreams because of the cholinergic effect of this medication. Rarely you can see patients with bradycardia, so they'll get orthostasis as a result of that, which means they'll get lightheaded really fast. And they might even get muscle cramps as well. The next class of medications to know about are NMDA receptor antagonists. And basically the only one to know about for this case is memantine. This one is thought to delay the loss of function in these patients by 6 to 8 months. It's often used either in substitution or in conjunction with the acetylcholinesterase inhibitors. And the primary side effects that I warn people about are dizziness, confusion, and hallucinations.